Hello, and welcome to this very special episode as part of the Global Liver Institute's International NASH Day celebration and recognition. I am Donna R. I'm the founder and CEO of the Global Liver Institute, which is the world's largest patient advocacy organization devoted to liver health. Through our more than 200 members, partners participating in campaigns like today, our councils, our events. We are advancing liver health in communities, with communities, for communities. And today we will be having a special discussion around the exploring the impact of NASH on high-risk populations. We know that NASH is a multifaceted disease, a disease that shows up in many different forms. And so we wanted to be able to discuss more specifically how NASH affects certain communities, certain vulnerable populations, and increase our understanding of how we can be helpful in tailored solutions. And so with me today, I have an incredible group of experts to help us explore this topic for the next hour. I have Dr. Diana Major, who is a professor of clinical nutrition in the Department of Pediatrics at the Alberta Diabetes Institute. I have Dr. Puneet Puri, who is a gastroenterologist at the Hunter Holmes McGuire Veterans Affairs Medical Center in Richmond, Virginia. And I have Dr. Jorge Emilio Lira Vera, who is a hepatologist and gastroenterologist, head of the liver clinic at the Hospital Central. And I'm so excited to welcome and recognize all of you. So I'm going to ask sort of each of you in turn to discuss some of the challenges in the specific populations that you work with, prevalence, risk factors, some of the long-term implications, and things we need to keep in mind since NASH is not a one-size-fits-all disease or an approach to helping people with the condition. So I'll start with you, Dr. Lira Vera. NASH is known to affect various ethnic and racial groups very differently. We have been to Mexico. We have sponsors of our International NASH Day from so many different countries that have populations across the Latin and Hispanic diaspora. Please tell us about the challenges that are faced by your communities.
Yes, of course. Good morning to everyone. Well, the prevalence of NAFLD has reached almost 24% in the Western population, and the risk of developing it's greater to the extent that a person has more components of metabolic syndrome. However, in certain populations, the estimated prevalence of NAFLD is higher. Ethnic differences in the prevalence of NAFLD have been reported, and well, Hispanic Americans have the highest prevalence at almost 45%. However, this appears to differ among different Latino populations. For example, individuals of Mexican origin have the highest prevalence, around 22%, and then it's followed by Central Americans, South Americans, Cubans, Puerto Ricans, and people from Dominican Republic. A Mexican study published some years ago showed that almost 57% of the NAFLD population has NASH. So this is something that worries us because biochemical and metabolic parameters worsen as body mass index increase. So in Latino population, obesity is the most common risk factor for developing NASH, followed by type 2 diabetes and dyslipidemia. Other non-risk factors are male sex, advanced age, and PNPLA3 polymorphism in the Mexican population. So this is how NASH affects us. And as Latinos, well, there is a lot of concern about how our lifestyle could affect the development of NASH in our population.
That just shows how important it is to really drill down into specific cultures and populations, because if we put out screening guidelines that are based on a general population, we could miss a lot of people without bringing resources to Hispanic communities, it would seem. So, Dr. Major, I'll go to you next and talk about children with NASH. I think there's a misconception that children don't get liver disease, and certainly some of the messaging around NASH is that it takes decades to progress, and so how could children possibly get NASH? Can you tell us about
Well,
NASH?
NASH has been reported in pediatrics in children as young as 18 months, though that's not that common. It's more common in adolescents, overweight and obese adolescents, and the prevalence is being increasingly reported in the pediatric population. So you definitely can get NASH. Typically, when patients come to our liver clinics, though, we see more children with fatty livers, as opposed to NASH, like proportionally, but still we have at least 1/3 of the population of children with NAFLD that do have NASH. So indeed, you can get it. And very similarly, in terms of the risk factors, overweight and obesity are the biggest, but also associated with dyslipidemia, hypertension in kids, and type 2 diabetes is starting to emerge as well. So it is quite concerning that children, as young as 2 or 3 who are overweight and obese, who perhaps weigh 30, 40 kilograms at 3 years of age, can be exhibiting the early stages of liver disease. And that just makes us even more concerned for the relative risk for the development of cirrhosis in early adulthood, and whether it will continue to exhibit cirrhosis earlier in the early 20s as opposed to maybe 40s or 50s. So I think it is really an important risk factor. And in Canada, we often refer to NAFLD, both in adults and in pediatrics, as a tsunami of liver disease. And that with the high intake of ultra-processed foods, high fat, high sugar foods, and the increasing prevalence of obesity worldwide, that it's likely to occur, and NASH in particular is likely to start to present itself in greater numbers in pediatrics.
Wow. This is why we've talked about NASH in the context of our liver health as public health initiatives as well, because of the importance of prevention and bringing all of the public policy levers, whether they are recess through schools or sodas and things to make sure that children, families, young adults, every age group is not in an obesogenic or a NASH-inducing environment. And certainly hearing those troubling statistics about children having advanced liver disease and cardiovascular disease really makes the case for that.
And certainly the food environment in schools and in daycare centers really do play a big role in terms of contributing to the relative risk of obesity and developing NAFLD. So I agree with you on that.
Absolutely. So Dr. Puri, you...
Hi.
Hello. Tell us about veterans. The VA health system has done some remarkable cutting-edge work in liver cancer, in so many ways of addressing liver health in veterans. But tell us about what the special challenges and vulnerabilities are in treating veterans with fatty liver disease and NASH.
I think this is very germane to the very concept of what everyone is noticing with the prevalence of obesity and the metabolic risks, including diabetes and other components like hypertension and hyperlipidemia. So veterans are of course, no exception to this. In fact, it appears that they may have a higher prevalence of some of these metabolic risks. In general, men tend to have a little higher prevalence than women. And as you would know, veterans have like 90% of our population that we see in our setup is predominantly all men. All right, so that does increase the gender-based differences and include. There are two particular things that come to my mind. One of this is that there are environmental exposures that many of these veterans are exposed to, certain chemicals, certain toxins, and that whether has any bearing in accelerating or promoting their disease development in addition to the underlying common known metabolic risk factors. And second important thing that I observe and has not been well studied and probably will be hard to study is prior exposure to alcohol. A lot of these in their younger days drink actively or heavily, and it's hard to quantify what they drank 20 years ago, but certainly they do admit that they had phases in their lives about 5-10 years of active drinking. So whether that kind of set up a thing of like predisposing them to second hits with metabolic risks as they develop during their adulthood time. So I think those are two very big factors. Third thing that I'm noticing is that compared to Diana's observation in children, we are seeing a population predominantly in their 60s, 70s, and even 80s who are relatively healthy. So, like elderly NAFLD is big on our radar. Like it becomes hard that patients want to know that what's happening to their liver health, and they are in 70s or 77-year-old getting a fibroscan, and then once you find that they have high liver stiffness, whether you should biopsy someone at that stage to confirm they have cirrhosis or no, or advanced fibrosis. So those are some of the unique challenges that we are running into, is that our population does not just span to younger adults, but also the older adults, those over 65 in large portion or proportion. Um, Lastly, I would add is that there's also a fair amount in our population presence of Black population, almost 30 to 35%, very comparable to national statistics, I would believe. And so, fortunately, they don't seem to develop that significant or progressive liver disease compared to other ethnicities and race.
That's really good to understand so that we can give people a personalized, risk profile, basically. What I wanted to explore just a little bit deeper, you mentioned FibroScan, a type of imaging and non-invasive testing. Can we talk about with all three of you the importance of non-invasive testing versus biopsy to your populations? Whether Dr. Major, I would expect that parents would be much more comfortable having a non-invasive test for their child versus a biopsy.
Definitely, that's true. I think one of the challenges, though, is in the screening for NAFLD in children, because a lot of primary care physicians don't recognize that you can still have NAFLD in the presence of normal serum markers of such as ALT. And so I think the lack of screening, routine screening in obese children who might have a dyslipidemia, for example, is part of the reason why they don't screen for it, is because they see a normal serum ALT, AST, and they go, oh, I don't want to put the child through an invasive biopsy. Right. So the use of ultrasonography or FibroScan would be a good tool for primary care physicians to access for screening as well as just even simple tools like looking for large waist circumferences in overweight and obese kids. Because I don't think that primary care practitioners recognize that even those simple tools can help triage or make some decisions about whether you should refer for an abdo ultrasound or not. And there are children whose body weights are within the healthy reference ranges, but still they have a large waist circumference and visceral adiposity, and that puts them at risk for having NAFLD.
Dr. Rivera, do you think that non-invasive testing would make communities more comfortable with getting screened and help us identify more people?
Yes, of course. I think laboratory and imaging studies to identify people in high risk of developing NASH, it's essential. And for example, we can use to estimate the risk of fibrosis parameters such as FIB4, even prior to elastography. We can make this kind of screenage in people just with the age, AST, ALT, and platelets. And then we can assure the patient which is the next step in every case. And we could performance liver elastography in case of high risk of fibrosis. I think it's very important for the people to have a test that could be easily performed with no major risk. And for example, this kind of test based on ecography or ultrasound, it's very important because it puts the patient at no risk. So for example, for the Latinos, it's very important that when a test is performed, there is no pain or to feel uncomfortable. So the non-invasive tests are essential in the management of Latino population about NASH.
I think that nobody likes pain. Having had 6 liver biopsies, I'm definitely biased towards having non-invasive testing. I'll just let that be known. But I think as we talk about scaling this to the tsunami that you talked about, Dr. Major, we need to have tools that are scalable as well, and so that we can address this. I wanted to talk just a little bit about the genetics. Dr. Rivera, you mentioned the PNPL3 gene that predisposes some people of Hispanic descent to more rapidly developed NASH. How are we educating people about the role of genetics versus these other factors, and how widely available are genetic testing for people?
Well, the availability of genetic tests it's very limited in our country. It's just used for researching, but not in the general population. It's very important, the education campaigns, because since there is not a lot of availability of the test, education is the most important thing. For example, in our society, high daily caloric intake, especially sugars, fats, and carbohydrates, results in weight gain. So in those people that have the mutation, it's easier to develop NASH and even NASH cirrhosis. And we cannot forget that even alcohol, it's harmful, not just because alcohol can induce insulin resistance by inhibiting some signaling pathways. And in our population, alcohol is an important modifier of NASH as it increases the severity of liver damage. So as we cannot be able to test the PNPLA3 polymorphism, it's very important to educate people, because when they have this polymorphism and gain weight, this could be very harmful to liver health. For example, in the last published National Health Survey of 2 years ago, we found that almost 35% of our population has overweight, and 36% has some degree of obesity. So this means that only almost 25% of Mexicans have an appropriate weight for their height. So the problem is even greater in women, as obesity is found in almost 40% of our population. So this is very important because as we are not able to test the PNPLA3 polymorphism, the changes in the lifestyle, it's very important.
Dr. Puri, what does genetic testing look like at the VA or at different VA centers?
Right. I think I echo the same sentiments as Dr. Lira Vera in terms of its availability and applicability in current clinical practice. It is largely limited in terms of decision making or identifying population at risk, but there have been some discussions among the committees at the national level to kind of integrate in a cost effective manner where this can be leveraged. Of note, the VA has something called the Million Veterans Program, and which is unique initiative by the Veterans Affairs in terms of studying 1 million veterans with their genetic information. And some preliminary data were presented at the recent ASLD meeting in 2022 that did show that there is high prevalence of the PNPLA3 mutations in this particular cohort as well. And I've not followed the work very closely to see. I think it probably may be out in print already, but if not, it did show some evidence that this approach can be integrated in a select fashion, where because it's a population level, you have to be also cost effectiveness, because if you expose thousands and thousands of people with doing this test, which becomes cost, whether it's cost effective or not.
Right. Having been on the, I'm married to a geneticist, which is my other bias. I must disclose, and so having the genetic information to better personalize, to understand disease, to better personalize, care, and help sort of explain the puzzle, particularly in such a heterogeneous disease, is always something that's interested me. And I know that the VA has one of the most diverse biobanks available in the country. And so as we are looking for these signs and signals of what works and what doesn't, having a large set of biosamples from as many diverse populations as possible, I know will really help us, create the medicines of the future.
Absolutely, yeah.
So I wanted to put that in. Well, one of the things that we do know, though, about the present is the bidirectionality of NASH with type 2 diabetes. And maybe Dr. Major, you can start us off in talking about what makes having type 2 diabetes so vulnerable for NASH, and how NASH causes or can drive more diabetes, and explain that connection.
Well, I think the connection is related to the hormonal environment of obesity related to insulin resistance. So children and adolescents with NAFLD develop insulin resistance, and they often have hyperinsulinemia. So their glucose levels are normal, but definitely that cardiometabolic changes of insulin resistance can drive metabolic changes both in the liver and in the periphery, which can contribute to an increased risk of, abnormal glycemic control occurring. It's not that common in children for the two to go hand in hand. You certainly have an increased risk factor. Children with type 2 diabetes, probably about 30% of them are at risk for having a fatty liver, but you don't usually see the full spectrum of NAFLD if type 2 diabetes is the primary diagnosis. But definitely into early adulthood, the risk for that would be potentiated and increase.
Other doctors talking about type 2 diabetes and fatty liver disease and NASH.
Right. Yeah, I think very appropriately stated in sense of insulin resistance being the common denominator, and how with presence of fatty liver, there is impaired handling at the level of the muscle as well. So when the insulin disposition and sensitivity is impaired, you kind of manifest more with the resistance. And very interesting in our own observation, we utilize fasting insulin levels in patients that we are seeing in our intervention clinic, like what we call as a metabolic liver disease clinic. And we do notice two things, like in prior questions that you had asked about, like non-invasive testing. So we looked at those patients who had liver biopsy confirmed fatty liver and different stages of fibrosis, as well as whether they have presence of NASH or not, because currently that is probably the only gold standard way to know. So what we found was one of the goals is, from the population level standpoint, is to recognize or identify people who are at lower risk, because the lower risk is a lot more likely than the high risk population, which many of the liver centers try to adopt. But if we can recognize who the patients who are at lower risk, we can guide them more to be followed into primary care practice. So I hope you're okay.
Thank you. I'm so
Yeah,
sorry. As
yeah.
I disclosed to the panelists, and I'll now disclose to the audience, the air is attacking me. I have
Oh,
severe allergies this season, so for all the allergy sufferers throughout the years that I did not empathize with to the extent that I should have, my sincere apologies.
no worries.
Yeah,
Yeah, I
no
hope you
worries.
feel better. Yeah. So you can take some water while I talk. So the important things in our observation were twofold. So one, when you don't have either an access to, say, fibroscan or even an ultrasound, can we develop models to identify patients who are at risk, low risk, like F0 to F2 versus F3 to F4, which is the stages of fibrosis? And we found two things that popped up in our data set. One was that FIP4, the what Dr. Lira Vera just emphasized, was the first cutoff point in decision tree analysis. FIP4 of 1.34 or less favored those that will have low risk. And when you do the next step, those that had low FIP4 and did not have GERD were the almost 90% probability of having low risk of fibrosis. So which is very interesting observation in this set of cohort patients. But when your FIP4 was greater than or equal to 1.34, what stood out was that if you have combination of diabetes and obesity, those are the patient at highest risk of having advanced fibrosis, F3 and F4. But either obesity or either diabetes alone had lower risk relative to the combination of the two. So I think these are some important directions and observations that can help us kind of expand this and test and validate this in a larger population, because it can guide the decision making in larger health systems like Veterans Affairs, where nearly 10 million veterans are seen across different parts of the country and outside of the US as well. So
we have benefited so much from the participation of diabetes advocates in our NASH Council, and they're universally, shocked that this information about the connection between fatty liver disease and diabetes has not been part of their conversations to date, and so we're going to really lean into those partnerships with the diabetes community
yeah,
to make sure that those patients who are so highly disposed, are put at the front of the line for screening and for treatment. And as we see many of the diabetes treatments or treatments for NASH coming from the diabetes community, the role of endocrinologists and others will be, I think, a really important part of the NASH treatment story.
yeah, I think those are very important points from diabetes. And if we time permits, I can share some
Mhm.
very recent observations we just submitted to the liver meeting. I hope it is received well.
Yes, and for example, several studies have now shown that individuals with NAFLD or even NASH are at higher risk of developing type 2 diabetes. But this relationship is bidirectional. People who develop type 2 diabetes are also at risk of fatty liver disease because liver steatosis is associated with alterations in both lipid and glucose metabolism. And this pathophysiological mechanism underlying the development of NASH, what are mainly the alterations in glucose and lipid metabolism, absolutely insulin resistance, insulin secretion. And these factors can explain the close association between NAFLD and type 2 diabetes. Something that worries us here in the Latino population is that now even younger people have obesity, even younger people have been diagnosed with type 2 diabetes. And this close relationship makes that at younger ages, the complications of NASH and obviously type 2 diabetes can appear. And these have a very bad impact on the community health.
So we are, doing this webcast today and encouraging all the activities of International NASH Day to have everyone step up to NASH, as this year's theme is. What I want to ask each of you, what do you think is necessary to really bring awareness to communities so that this is prioritized in the way that it should be, can be, given how many people are actually affected? Dr. Major, what do you think we need to do to reach children and families?
Two things. I think public advocacy and sharing the knowledge with parents and families are really, really important in terms of setting up a healthy environment for children to participate in physical activity and eating healthy diets. And then in the school and daycares is fundamentally important because that's where children spend more than 50% of their time. And so educating and public advocacy for those same factors in the daycares to promote awareness of healthy food choices and the importance of routine physical activity in terms of liver health, I think is also really important. It's sad to say, but many people don't they hear about cardiovascular health, but they don't necessarily know what the liver does and how important it is for metabolism and to lead a healthy life. And so I think it is really important for public advocacy in those kind of targeted segments of the population are really important. Same thing for recreational centers as well. There's evidence to show that the food machines, the food available in sports arenas often are not healthy, and are fast food, high in sugar and fat, and some importance about identifying, prioritizing healthy food choices in those fast food outlets as options is also really important, I think, because children spend a large measure of their time there as well.
I've been amazed at seeing vending machines with, salads. And so there are healthier options that are available even in those types of convenience settings. And so maybe shining the spotlight on more of those and helping those to scale.
The challenge with those, though, is that they're very expensive. Fresh produce is very expensive, especially since the COVID pandemic.
Right.
And food insecurity is huge in the North American population and other parts of the world. And so it's sad to say, but the price of fresh produce has, tripled compared to fast food, which has increased in price, but not at the same kind of level. So I think advocacy to policymakers is really important about prioritizing and looking for avenues to help blunt some of that increased cost of fresh produce, because definitely that's a barrier. People are going to choose the least expensive, so-called tastier options than the fresh produce. So I think it's a little bit of a mixture of the approaches that need to be taken.
It's sort of like the other side of hunger. So we hear a lot about food insecurity in terms of people, unfortunately, being hungry. But even if they're fed the number of calories, they may still be undernourished.
That's right.
Okay, excellent. Um, Dr. Puri, what are some ideas that we can do to make sure that the things that we're talking about today really reach people and really resonate with people?
I think like you hit the nail on the coffin thing, kind of a thing. Like Step Up is a very big initiative. In addition to food, physical activity, like kind of deserves a fair good bit of attention. And it is easier said than done because it's very hard to like implement, even if we can like put it on our own self and see how active we are and how
Mm-hmm.
much effort it takes to become like even to reach an average goal of like 10,000 steps. I was just in mind of what is coming was looking at like what it takes to like it is about 5 miles of walk to make
Mm-hmm.
it closer to your 10,000 steps goal. And why that number of walking steps important? Maybe that it overcomes the sedentary behavior, it overcomes the downstream effects of sedentary behavior, which now has become to be recognized as worse than smoking. So, so I think it is crucial. Big barrier to our patient population are twofold. One, that many of these are like combat veterans and
Mm-hmm.
have had suffered some kind of an injury over the process. So that has been a big limitation or a barrier from that standpoint. And two, that patients who have already like have excess body weight find it very hard to be able to like do activities that can relate to like improvement. If you talk to the veterans, they say like, hey, I was busy in the drill that kept me my healthy weight. We have a good way of tracking system here, like patients who have been in the system for 20, 30 years,
Mm-hmm.
that what their weight trajectory has been and how is it fluctuated and all. So those are some good glimpse, and they kind of I show them to say like what are your goals, because we have to set up a reasonable goal what you can do. And when they are on the other spectrum with limitations, then
Mm-hmm.
I think diet plays a more important role, and then slowly as they lose weight, that is where you start increasing their activity. Some suggestions I feel that may help and benefit, and as such we have it very good at our own VA, that our parking spot is a little far. So when you park the car to get to work, it takes you nearly 8 to 10 minutes to reach. So that gives you a decent some counts to steps. And yesterday I was trying to count it. It is close to 1,000 steps that you get. So at least you get 2,000 steps just
Mm-hmm.
coming and going to work, right? So that's one way. We should also try to see if there are ways that people should be encouraged to take stairs, even
Mm-hmm.
if like one flight of stairs is added. You see this very common that people are getting into the elevator on first floor and getting off of second floor. So if there is a little more awareness that like
Mm-hmm.
these steps count towards their healthy you, so that we can add more value to these places. That is one thing. We have something called like an employee wellness program as well here, and I would encourage if institutions or organizations or in what way you can engage more public awareness and participate in physical activities. I recall one of my old friends from India. He did this in his own city, like a city of the size of Richmond, that he made heart health as the prime. He's a cardiologist, interventional
Mm-hmm.
cardiologist, but he shifted his attention to prevention. And you would not believe, like he has over 200,000 followings on like social media,
Mm-hmm.
as well as like over 10,000 people in the city participating in activities as groups. So something that can bring the groups together in their own communities if we can foster that through advocacy, through policy making, or even like insurance is supporting that, because like insurances find it very hard to support these kind of healthy initiative, wellness initiatives. And what Dr. Major pointed out, like healthy eating costs a lot more. So how can the initiatives go down to make it more affordable and accessible?
I think those are excellent and actionable things. We have a kit for employers who want to do NASH education workshops with their employees this year. So I would encourage anybody listening to download or ask for those materials. And one of the highlights I know of last year was our, International NASH Day logo on bicycles throughout India as that race. And so as we continue to build on this, allowing communities to adapt to whatever fitness activities that they're doing community wide, I think is exactly what we want to encourage. I took the time on
Can you see this
I think
thing?
the background is exploring. Okay, right there.
There you go. Achievement.
Yes.
Right there. Certificate of achievement. Yes.
Healthy lifestyle challenge.
Congratulations.
So
That's
thank you.
fantastic.
So this is the initiative our team, so my own colleague who kind of is my right hand to our NAFLD or metabolic liver program, Ms. Joelle Lemons. So she and her colleague, nurse, both of them planned this healthy lifestyle challenge for the employees here within our own GI division. And they did every Wednesday like exercise at work, and they gave us some bands that we could use where like so to try and activate that. And I think that Felicia and Joel were like great help, and as a part of this upcoming NASH Day, Felicia plans to do in our multi-purpose room like a workout of 15 minutes to try to see how people can use common like not going to gym or common day-to-day things at home to make like activity also as an important component to their healthy living.
And resistance exercise is so important for patients with liver disease, because often they experience lower muscle strength, lower muscle mass, or frailty if they're older. And so resistance exercise is a gentle way to start. It's not high impact. It's not hard to do. You can do it sitting at your desk. You can do it sitting down, and you can do it. There are lots of videos online that can give you like simple way, but an actual resistance band is not very expensive. It's probably the least expensive way to do it. And also, you can work on flexibility so that you don't want to give up, because if you're overweight or obese, you might get injured, have joint pain. But with resistance exercise and stretching and flexibility focus, it's a good way to start, in addition to all the other strategies Dr. Puri mentioned about parking further away, walking upstairs, and can be quite effective.
I absolutely agree. I have a little set of weights right behind on the other bookshelf, just so in between things I can, when I'm not dying, that I can sneak in a little workout. Bands, there we go. We'll do a special one of hepatologists working out, and I know Dr. Jonathan Stein always challenges me to head on my Peloton bike right before my speeches sometimes. So Dr. Oliveira, your ideas for raising awareness and engaging communities.
Yes, I think the importance of increasing awareness about NASH is that it does not only bring liver complications. People with NASH, as we discussed before, are at high risk of developing type 2 diabetes, but also cardiovascular complications, including high blood pressure, ischemic heart disease, even stroke. And these are serious life-threatening diseases that involve high healthcare costs. I don't know why, but when at least Latino population hear that their heart health is at risk, they start to change the lifestyle. So I think education campaigns should focus on raising awareness of NASH relevance, and that the damage does not only occur at the liver, and that its early detection and treatment will improve the prognosis. Campaigns should educate people about what is a healthy diet, appropriate for each region, even in our populations. The food can be different, and we can explore healthy options that help us to lose weight, how to do effective physical activity to lose weight, and we can show people that doing physical activity can be cheap, because sometimes the people tell us that they're not doing exercise because a gym is expensive, but we can show them that even walk, run, swim, even dance, it's for free, and it's very effective to lose weight, right? And
And
it's
it's
also
fun
very
too.
right. It's fun, and it's also very important to educate how to avoid other factors that increase the harm of NASH, such as alcohol. In our population, alcohol is also um, a risk factor to liver disease, and also a combined damage with NASH. So I think when patients understand their disease and see the good results that weight loss brings, they encourage other patients to have good adherence to treatment. So as Dr. Puri showed us before, congratulate the patients when they reach the goals. It's very useful because they feel comfortable, they feel that they are reaching the goals that we set, and they help us with other patients to encourage them to change the lifestyle.
I think that's great. Just to add, Donna, to Dr. Lira Vera's comment, uh, the VA system also encourages, like, because as I said, a lot of physical limitations, back pain, or others, they have like a lot of water-based exercise programs, including, like, say, the water aerobics, or so those who cannot bear weight can use that to increase their activity, and including natural resistance to water part.
I think that's important too. I know I learned to swim as my knees were failing, so I went into my knee replacement surgery strong. But it's been a
Wow.
fantastic exercise to keep up um, for now several years afterwards. But my highest step counts have come from days when I danced, and so I would definitely be remiss if I didn't recommend dancing as really fun, easy way to get your steps in that doesn't seem like working out or some type of forced
Yeah,
thing. Also, the
it
social
is.
connections.
Yeah, that's what I was about to say, that there was a recent study that came out from like observation of folks from like study that looked at like what are the elements that could predict longevity or the longest
Mhm.
survival. And of all, like, none of these common diseases emerged as the worst predictors. However, a good predictor was the social connection that seemed to have played the most important role in people who survived the longest. And they also had a message that people, like especially for men over 55, having a pet such as a dog also increased their lifespan by a few years. So all those things can be shared, as Dr. Lira Vera said about education and awareness. If we share these positive aspects, because many people obviously feel dancing may be intimidating, but when they see this as a social connect, and like, as you said, it will increase your steps, it will increase your heart rate, it will de-stress you, and probably add more health benefits than thought.
Yes.
And for children, I think shaking it up a little bit, like more than one different approach to routine physical activity is important. Many kids with liver disease complain about not being able to keep up with their peers, like running around, playing. So I want to emphasize with young children in particular, play is so important for movement and to generate, steps. So that could be running, playing in the playground, running around the gym, going to the library, like in the middle of the school day and running. But also it should mean that the parents and the siblings are involved. With ongoing exercise studies that we're conducting here, we have really found that the older sibling and parental involvement in the actual exercise program increases adherence, and the family together has fun, and you're more likely to be successful at integrating change in the child if the whole family's involved. And for adolescents, it's not really their families as much as it's their peers, their friends, and what they're doing, and whether they participate as well. So I do think for exercise for children, you need to take more than one different approach, and usually group involvement is really important, whether it's the family focus or it's the peer focus. It'll change with the developmental age of the child.
That's really helpful. So now that we've engaged children, families, their communities, what do the policymakers need to do? Are there other stakeholders that need to be involved in this to help make all of our efforts successful? Dr. Puri, I'll start. I mean,
oh my!
just because you're, I think having the support of the VA system and being set up as a system, whether it's from my eHealthy Vet or some of the other programs that you started, has really provided the infrastructure for the work that you're able to do. So outside of VA, what could policymakers do to help us make health systems and communities better suited to support the types of activities that we've talked about?
So I think I can take this into two different dimensions. One is to, like, at a population level, when health systems like the VA, where you have like millions of patients across, but with wide variation and heterogeneity, both of the disease as well as access to different resources. Because from the public standpoint of view and policy standpoint of view, larger benefit is the key, with less expense, with effectiveness that can be implemented or implementable, right? So one big part would be how can we ascertain that the food availability is more uniform. Food availability, just not because if one were to see the major consumption of foods in different categories, if you just put, like, say, vegetarian, non-vegetarian, Mediterranean diet, whatever diet, regardless of the spectrum, if you just separate that into processed and non-processed food, just two big categories, my guesstimate is that over 90% of food consumption in the United States is largely on processed food. So if one were to see the direction of change that processing got implemented, just see, like, if you used to remember in your younger days the fruits coming on your table, they would not last long if not eaten. They'll get spoiled. Now, like, an apple can stay on table for 2 to 3 weeks without getting rotten, right? So what is it that has changed in the production or processing of even it appears like a unprocessed food, but there is something that has changed that provides that food to be more available. A lot of frozen dinners, frozen foods do affect. They are affordable, but their nutrient value and health benefits, I think, are significantly impacted and affected. So how can in policy we can focus on generating more whole foods in way of like providing at an accessible and affordable way, then second point is that those that already have risks, such as those who are obese or diabetics, can the like insurers, can the like employers, can others benefit those who already are disadvantaged because of their problems or medical conditions? Can they be benefited by some subsidy, some kind of like discounts in accessing the healthier options or versions, so that it's not like a whole cost? So the third thing being, like, there was a recent case of like alcohol taxation in Scotland and United Kingdom, and they could start seeing its impact. Like, if you tax these things with the higher and costing of those things that can be more detrimental become higher, then their consumption decreases, and its downstream effects also had significant impact. So could there be ways that those things are made harder to access for a lot more public, especially disadvantaged one? Because if you see that they reach out to inexpensive ways, sugar or alcohol or other addictions, then that may be something that we can ensure. If you could recall, in Europe, the subway was not deemed to be a bread because of the content of what the thing is. So those strict, because we had like visiting faculty from Italy, and I asked them as to how in Italy you keep yourself eating pizza and pasta still a lot slimmer. And the simple answer was the quality of food, as to what goes into the food, uh,
Right.
as like making the bread, all those things, and the portion control that they have, and then the activity. So all three things kind of made the mark. So something along those lines, where the determination and commitment is there to make healthier options readily available and affordable for vast majority of population.
And that can include changes in food regulation, right? In terms of the amount of additives, the type of additives you put in. Sodium reduction strategies in the UK have been quite successful about decreasing stroke incidence. So it is possible to move forward with legislations that would address that. I know the food industry may resist, but there are ways of making graded changes and progressions to decrease the amount of extra high fructose corn syrup, for example, reductions in those, or removal, reductions in sodium content of foods. And that could go a long way. Food labels are good for consumers to be able to learn how to identify what's a high, low, or medium source of a nutrient, but certainly more public awareness and education about that will help consumers make better choices too, because there are some frozen foods that are equally good as fresh whole foods, but the consumer needs help to identify those. And so I think the government can go a long way with changing food regulation and making positive graded forward steps with that, because there is evidence that that does help with long-term health.
Excellent. That's a wonderful, very specific action item for us to put on our agenda. And I'll give Dr. Lee Rivera the last word. I know how much it meant to us at GLI to be included in a meeting in Mexico City amongst the different health ministers, the different Mexican states, and hearing their commitments to metabolic and liver health. What is the next step? How can we be a good partner to the health ministers in Mexico to make that a reality? What should we be doing in partnership?
Well, I think probably policies should be tailored to each population, and maybe this is the best way to deal with the problem, because some communities have their own necessities.
Right.
And for example, some years ago, there were taxes about fast food and sodas, things like that. But that only brings that people spend more money in the food that they like, but it didn't avoid the harm effects, or the harmful effects of this kind of products. So I think the policies should focus on preventing the development of NASH. Our strategy should be oriented to the prevention of the disease. I think primary prevention should avoid the development of NASH. The secondary prevention should make an early diagnosis of NASH and provide a treatment. And tertiary prevention, well, at least should seek to rehabilitate the damage that NASH causes. We are doing some things. We are far from the goals, but for example, some health institutions have education programs to people about what healthy diets are. There are programs that invite people to join exercise sessions. You can sign a list and you assist to a community park, for example. We'll look to make at least 150 minutes a week. We can give ideas to some exercises at home, but we are far from the goal. I think as a community, we have to work together to making it clear that despite the variations that our population have, some measures are essential in all people with NASH. For example, more recently about foods and beverage, there are some labels that help people to know what products are rich in sodium, or for example, this food have high levels of carbohydrates. That's a good idea to help people to avoid some kind of food or drinks, because sometimes we say the people at the office, oh, you should avoid, for example, carbohydrates. But if we do not explain the patient what kind of food or drinks are rich in this kind of products, well, they are not able to know what is the most important things to avoid. So maybe these kind of strategies that are very simple but could be effective are very important to get the people the knowledge of how to prevent or even getting better about the disease.
I thank you. You all have reinforced really important messages that awareness is not enough. We have to give people the tools, as the supportive environment, as well as the information to help make these changes to prevent and to manage their fatty liver disease and NASH. This has been information that I know will help so many people and enliven not only this International NASH Day, but those to come. Thank you so much.
You're very welcome. Thank you.
Thank you.
And you can please follow, share, engage, retweet on all of our social media handles and on our website, globalliver.org. You can find all of the information about International NASH Day and download all of our NASH resources in, I think, 16 languages and counting.
Thank you.